Thank you for coming. Thank you very much. Thanks, Ken, for putting this whole thing together in Smart, Colorado as well. So I'm Steve Wright. I grew up in family medicine graduate in 1982. I started doing addiction medicine in 1987. In Santa Fe, where I was, a group came down actually from Colorado Springs wanting to put in an addiction treatment center. And I was looking for a medical director. I was young, I was hungry. I said, sure, I'd love to do that. I have no training, no experience. I don't inhale. I got the job. And loving it ever since. I love working with addicts. It's the most interesting group at all. So and attending, I didn't learn anything about addiction or pain management in my residency program, but I did have an attending who told me the way to avoid burnout in medicine is to let your patients entertain you. And and they certainly do, but it is a very big deal. It's not all about entertainment. And so we want to take here a deeper dive into the medical aspects of cannabis. And I don't want to be repetitive. Some of this will be, and I'll slide through a lot of that. You also hear somewhat of a different perspective on things, because I tell you, the literature is really quite challenging in that regard. It's beautiful, isn't it? Cannabis probably came originally from the steppes of Russia. The first document indicating use was actually a document from China about 5,000 years ago, where the emperor identified medical use, suggesting to use it for arthritis and, get this, memory problems. We didn't fast forward about 2,000 years. Pliny the Elder described for the first time the side effects, actually did a pretty good description, and a lot of other references as well. Cannabosum is actually the Hebrew word that for the anointing oil in the Hebrew Bible, and there's been some speculation as to where the origin of that is all about. Fast forward again, we have here Shakespeare, and so they were looking under the foundation of his house and found what they thought was his house, and they found a pipe. And they said, well, let's find out what old Bill has been smoking, and they identified cocaine and cannabis. It's interesting that in one of his sonnets he said, and keep invention in a noted weed, we don't know what that's all about. Fast forward again, this is in 1895, a product recommendation here for maltose cannabis. And if you look quite closely here, it must be good because the Red Cross is there and a small child. This is no patent medicine, but a nourishing food remedy. So, no end of misrepresentation over time. But I would encourage you to look at your own bias as well. In ISNN, we don't see things as they are, we see them as we are. We all walk into this with certain biases, and I began and worked through my day setting aside the bias and taking a look at what the evidence says. And the evidence is really challenging to sort out, as I'll talk about. What does this guy see? Well, he sees this, Colorado, where prohibition ends and the fun begins. We have the retirement plan. This is a 420 retirement plan that some people envision in relation to that. And job opportunities. Here we have DU offering a professorship for pot law. And then another perspective as well, you remember reefer madness, a violent narcotic public enemy #1, soul destroying. Probably not, the perspectives are not quite on the mark in any particular way. So we want to take a look at the epidemiology of cannabis use, a little bit of that. Look at the various products that are out there, and then look specifically at a few of the medical aspects of cannabis, because there's a lot of misinformation out there, and it does depend on how you interpret the data. So epidemiologically, we see that about 40% of us have tried cannabis. Last year use, nearly 10% last month, and that's the definition in the studies of current use, by the way, is last month. About 19 million, and about nearly 6 million are using on a daily basis. You can see that's nearly doubled since 2006. We have 6,600 new users every day in the United States. And a lot of these are kids. 2014 data, by the 8th grade, 16% will have used at least once. You can see here change over time, used by 12th grade. The peak was actually in 1979, dropped down to 35% here. The data I saw, 44%. And here we have that last month or current use in 12th grade, 21% here. Average age of first use, 18 years of age. Incidentally, if we get this on a PDF or in a jump drive for folks, you can actually click on these. You don't have to believe anything that I say. You can click on these and see the original articles themselves. So what about medical use? And I'm not going to dwell on this a lot, but I want to highlight a couple things here. First of all organizations and the literature in general recognize use but needs more research. That being said, a couple guidelines have already included it in terms of the recommendation. It's not first line in any guideline, but you can see here even the American Academy of Neurology, and again you can click on these references and actually get to those, and the Canadian Fibromyalgia Guidelines. So it is out there. Why would it be out there? Well, the endocannabinoid system, and that's the cannabinoids that we all carry around, is probably the most diffuse, diverse system in the brain, more so than any other neurochemical system, and it involves a variety of different aspects: appetite, mood, thermal, temperature regulation, response to inflammation, stress, neural injury, and the circadian rhythm. I'm not going to get into detail on all this, but it probably is relevant with regards to sexual activity, reproductive physiology, suckling, bonding. If you, with rats, block cannabis, the cannabinoid receptor, the newborns die. It's an important issue in relation to bonding in some way, motor function, executive functions, on and on and on. And again, I'm not going to dwell on this either, but you can see that the receptors that are affected, we have the classic CB1, CB2 receptors. GPR receptors here also are activated in relation to the cannabinoids. But secondarily, you can see a lot of other receptors that are actively involved. And so I point this out to indicate that this is very, very complex. And it simply isn't true that we haven't been studying this over the years. We have many, many studies, as Dr. Hildebrand pointed out, but a lot of it, because of its complexity, has to do with the basic science and animal studies and not the clinical aspects where, of course, we really want to have more and more information. This, too, I don't want to dwell on as well. This is tetrahydrocannabinol, and the various effects there. It is a partial agonist of the CB1, CB2 receptor, but many, many effects have been identified here in relation to THC in and of itself. It is essentially the product, as we heard earlier, with sesamet and marinol. These are synthetic or cannabinomimetic products. I want to note here with regards to use, lower abuse potential was claimed, at least one study indicating a comparison between smoked cannabis and marinol. Less abuse was identified in that particular study. So there's an opportunity for us as medical providers to provide a well-researched product that may have some value in certain selected circumstances. Cannabidiol, as mentioned earlier, there actually probably is a very slight psychoactivity associated with that. It's not totally without psychoactivity, but it certainly does not have the psychoactive properties of THC. But again, lots of different studies suggesting effects here that are important. We have the anticonvulsant effect, the Charlotte Webb issue. I want to point out that that has really not been well represented in science until about 6 months ago. The only article out there was an internet survey of parents with kids with seizures, and that's not science. And Dr. Hildebrand mentioned this study looking at kids, in that particular study, there's about a 56% favorable response rate in kids that had these intractable seizures, Lennox-Gastaut syndrome, a Dravet syndrome. That's a very big deal. I actually had one of these patients come into my practice. Parents brought her in, and they said, you know, it was really quite remarkable. You just put it under the tongue, and seizures that typically last for hours, it went away. So it probably is something to it, but we do not have yet the science to support all the claims that are out there. So we do have these the various products, the Sativex nasal spray, the THC's cannabidiol combination, about a 1-to-1 ratio. You're going to hear the term nabiximols, and that refers to that combination product. It's approved in a variety of countries, Epidiolex as well, Namisol, Canador. These are products that are in other countries that you may see out there. And just to wrap up the medical part, there is no level A evidence for cannabis plant, oral vaporized. We shouldn't be smoking medication in my perspective on this, but you do have some level evidence supporting neuropathic pain, cancer pain, spasticity. One reviewer indicated Tourette's syndrome. I pulled that off the list because I took a look at the literature and was not very impressed. But we do see, you know, lots of literature in relation to pain, acute chronic cancer, neuropathic, spasm-associated migraine, prophylaxis, fibromyalgia. It's all over the place, and it's hard to adjudicate this literature in terms of saying this has value or not. But probably, if anything comes of this, it's probably going to be neuropathic pain and abdominal pain that is probably going to rise to the top, if anything at all. There was this study, dronabinol may work as well, lasts longer, and has less euphoria. Again, a product that is produced by a pharmaceutical company with the studies to go with that. Certainly, medical providers need to look at that as well. And the reviews indicate that the studies are really quite limited, that the benefit is modest, and there's significant concerns about the harms associated with that. There is a lot of things that are going on, and you can see here the various disease states that are involved in the various articles here. So there's a lot of work that's going on, but again, not a lot has risen to the top. And you tell me, these are the medical products out there, right? You know, AK-47, Blue Dream, you know, we don't call our pharmaceutical products this. I would argue that this was really not the intention of the medical dispensaries to dispense to individuals that are out there you know, looking for medical use. And I would argue that gummy bears as a delivery system is not necessarily a wise idea as well. So this is the way I divide out the various products. There's a cannabis plant and plant parts. There's products that have THC as more of a concentrated form. That's the marinol, sesamet, namisol, but also the butane extraction that we already heard about. The synthetic cannabinoids, they are a very big deal. The cannabinomimetics, the desired effects include empathy as well as euphoria and well-being, but it can be devastating. Panic, psychosis, violence, acute renal failure, and death has been associated. And then what I call the cannabidiol enriched products, that's the Sativex, the Epidiolex, and Charlotte's Web. So are we embarking on an experiment that has trouble written all over it? There are three kinds of men, ones who learn by reading, ones who learn by observation, and the rest of us have to pee on the electric fence. Are we doing that? We saw promoted before the recreational use amendment was passed. For many reasons I prefer marijuana over alcohol. Does that make me a bad person? A very rhetorical sign in our community. I imagine many of you saw it. No, it doesn't make you a bad person, but you know, that safer than alcohol argument is one that we need to directly look at. Can it be a substitute for alcohol? And that argument has been made, where you're going to have folks transition over to cannabis, not use alcohol where there is greater harms. But I want to remind everybody that alcohol at a safe dose reduces cardiovascular death by 25%. There is nothing about cannabis that reduces 25% death rate. alcohol causes impairment at the directed safe dose. So if you are under that safe limit, and for men that's no more than 1 per day, for women no more than 2 per day, for women no more than 1 per day, if you're at that safe level, you're not going to have impairment. The goal of using cannabis in the recreational population is impairment. And alcohol measurement allows impairment to be managed. So I can identify a couple hours later a blood alcohol level that I can extrapolate backwards and say, at the time of the car accident, your level was this. You cannot do this with cannabis. THC drops down and then levels off with a slow taper off, and so you can't extrapolate backwards. So we can't manage the overuse impairment activity that individuals might be involved with in relation to car accidents or other things as well. So I would argue that it's better described as having a different safety profile. We have, of course, medical giants like Willie Nelson and Arnold Schwarzenegger calling it a natural herb, and I would always remind my patients that strychnine is also natural. We went through some other products as well. We don't use a lot of strychnine these days. They actually did in the past, because it kind of at a very low dose would give you abdominal cramps, and you think your medicine is working when you feel that. There are some personal liberty arguments that are brought forward by the lawyers, and you might want to take a look at that. That's actually well argued for that particular position, not that I support that, but you got to keep in mind that the issues around personal liberty always faces off with harm and potential harm arguments, and that's important to all of us. Cannabis sativa is the one with a heavier head effect, euphoria, it's more psychoactive. Greater energy, so daytime use is predominant. CBD THC ratio is lower, which means there's more THC. Cannabis indica, heavier body effect, less psychoactive, more sedation, so nighttime use. Just so you're familiar with what's out there, I remember cannabis indica as a nighttime use by remembering into bed, indica, and that's the easy way to do that. The delivery systems we've walked through, smoking, vaporization, orals, which is sort of a long-acting form, but there's also in the mouth, rectally, and on the skin that's out there. The research is really quite challenging because the literature very much observational with small sample size, and a lot of the literature will push all the cannabis products together and give their conclusions in relation to that, but they are indeed all differently. Most studies look at smoked cannabis, not other routes of delivery, and there's quantitation problems that are out there in terms of the amount of THC. There's variable dose, variable frequency of use. Smoking technique, individuals tend to hold their breath in longer than with smoking tobacco. And as we mentioned, as was mentioned earlier, higher concentrations in the products. We do know, however, that you can't necessarily translate recreational use studies to medical use, because medical use individuals are going to be using a lower amount. I've actually seen some valid medical patients using, and they do, and it is possible to do this without impairment, but it is quite challenging, and those individuals are really quite rare. It's hard to imagine that there are 114,000 residents of Colorado who can't get their pain managed by other means, and that's the medical card is predominantly that. 94% have as their indicator symptom as chronic pain. There's the confounding of other drugs. A large proportion of individuals are also smoking tobacco. How do you sort that out? And the acute effects may mask the chronic effects of the drug. And so I want to highlight that association does not necessarily mean causal. Just because I have a cup of coffee in the morning doesn't mean it made the sun rise. And you'll see a lot of these associations. You know, crime rate went down, therefore it had to be the use of medical marijuana here in Colorado. Not necessarily so. So what about the medical associations? So overall physical health, only a couple studies out there, mixed results. Mental health tends to go down, lots of ER visits. Overall effect on mortality is indeterminate. There are, in fact, no overdose deaths that have been identified. but mortality is associated with cannabis, and the reason is cannabis is associated with cancer, cardiac disease, strokes, and motor vehicle accidents which cause death. So it simply is not true that cannabis does not cause death. It does cause death, not overdose death, which is really what is being said, but it can cause and does cause death. In recreational users, decreased quality of life, educational achievement, work success, income. There's more school delinquency, youth crime, relationship problems. I don't want to belabor all of that. Medically, we see eyes get red, oral health declines, heart attacks do go up. There is the cannabis hyperemesis syndrome, which is a phenomenon of high dose where there's nausea and vomiting associated with that. There's that interesting aspect about it of actually wanting to bathe. There's compulsive bathing associated with that, very peculiar, but it certainly is there. Endocrinologically, we see men growing breasts, hypogonadism, change in sexual function, strokes are present, and of course, as mentioned earlier, the burns from butane THC extraction are out there. Pulmonary. Now, this is one that surprised me. When a patient came in and said, you know, when my asthma gets worse, I just smoke a joint and it gets better. I thought, yeah, right. Well, it actually turns out in studies it does enlarge the airways. Now, it is not a good bronchodilator for individuals with asthma because it only lasts 1 hour long. But it speaks to the issues of how we walk in with certain biases, as I did with all of this, and you need to look at the literature to identify what's going on. We don't think that chronic obstructive pulmonary disease is associated with that, or emphysema. It does cause bronchial inflammation. There's greater risk of respiratory infections. There are fungal contaminants in some of the products, and we're worried about aspergillosis associated with some of the products that are out there. Chronic cough, chronic bronchitis is certainly there, tends to go away when you abstain. And the literature that I looked at, there are mixed results when it comes to lung cancer, which is really quite a surprise because you see here cannabis compared to tobacco. There's more of carbon monoxide, ammonia, cyanide, tars, and pesticide in cannabis products that are out there. Same number of carcinogens. Why do we not see more cancer in the studies that are out there? Well, we do see some cancer has now been associated with prostate cancer, testicular cancer, and brain cancer. Parental exposure can lead to kids having astrocytoma, rhabdomyocytoma, neuroblastoma, and leukemia at a higher frequency. And that incidentally is not just maternal smoking, but also paternal smoking being involved in that particular way. But what struck me as well, lots of mixed borderline results, but there are a couple studies out there suggesting that it could be protective of non-Hodgkin's lymphoma, squamous cell carcinoma of the neck, and bladder cancer. How does that work? Well, it turns out that a variety of the cannabinoids in the plant are anti-tumor, and so we kind of end up with these mixed results depending on the distribution of the various cannabinoids, 60 to 80 of them in a cannabis plant. We are going to be able to find some of the non-psychoactive cannabinoids as being valuable agents in cancer treatment in the future. What about psychiatrically? Well, when I look at the literature, there's actually mixed results when it comes to depression, suicidality, anxiety. One of the big problems out there is the nature of how the studies are done. A lot of these are question and answer studies where individuals say, do you feel good, do you have depression, etc. A large proportion of individuals were daily smokers and could have been loaded at the time of the study, and there was no separation of when you smoked a joint and answered the questionnaire. A lot of those studies will need to be redone, because picture this as we understand from alcohol. Acutely, if I'm an alcoholic, I drink, I feel a little bit better right at the front end, but it contributes to the depression and anxiety that I have long term, and so the question is not answered in relation to that. We do see paranoia in a number of individuals. It is now felt that it's not just associated but causal in relation to psychosis and schizophrenia. And interestingly enough, violence. There are only 3 studies out there that I can identify. It has been associated with an increase in violence, which is not what I thought I'd be seeing out there, but it was about a doubling of that particular rate and impulsivity. I do like Kathleen Madigan, a comedian, who says, my friends who smoke pot don't do anything bad. In fact, they don't do anything at all. And so one of the issues, of course, that comes up very frequently, I still get the question, does it cause addiction? The answer is a definite yes. If you look at the literature, 8 to 14%, and this extends way back, 4% Americans have cannabis use disorder or addiction, about 14 million of us. If you start early, there is a significant increase in the likelihood of becoming addicted. And those individuals that are using on a daily basis, and I'm talking about recreational at this point, not the medical users, about which we really don't know enough about 25 to 50% of daily users do have addiction. We have defined withdrawal cannabis use disorder is treatable, at least for the short term, and gateway actually is somewhat uncertain if you look at these studies. And I call this the Big Bong theory, the theory that cannabis starts off everything in relation to other substance use. What's interesting is that we are uncertain about gateway because there's a lot of methodologic problems associated with that. When you go to rat studies, there's one rat study out there that for cocaine preferring rats, if you prime them with tobacco, they accelerate their use of cocaine. But with cocaine preferring rats and priming with cannabis, they did not accelerate their use with cocaine. On the other hand, there was a rat study looking at priming cannabis in opioid preferring rats, and they did accelerate their use of opioids after that. So my personal feeling, once we can work this out, that like Dr. Hildebrand said, I believe that this is a gateway phenomenon. There's 2 aspects to gateway, by the way. There's what happens neurophysiologically that makes me more interested or vulnerable in relation to other substances. But the other thing is that once I'm connected to a cannabis production industry, I'm going to be exposed to just the opportunities for other substances there as well. So there are a number of risk factors associated with that. This is in your in what you have. I'm not going to go through all of this, but what this provides to us is some opportunities to run interference on initiation or continued use among our youth, and these are important. These are the addiction risk factors as well. We want to look at that. I want to run through some of the other effects as well. Psychomotor negative effects, so worse with acute and chronic use. There's increase in non-traffic related injuries. There's about a 2 to 3 times increase in motor vehicle accidents, even up to 2 times increase in fatal motor vehicle accidents. It is dose dependent, worse with alcohol, and interestingly enough, it's a little bit different than alcohol. It occurs more often with routine rather than complex driving. If you can picture the overfocus that is associated with cannabis use in complicated situations, these individuals can be focused on the task. In routine driving, they're kind of chill, laid back. I think in the highways of the future, you're going to have the HOV lane, you're going to have the regular lane, and then the Cheech and Chong lane as a way to deal with that. The risk persists 4 to 6 hours. That's what the studies show. I don't know that I quite believe that. That's smoked marijuana. Remember, the edibles can last much longer. Cognitively, also, problems with acute and chronic use, multiple domains are affected, decision-making, judgment, things like that. Worse if you start younger, use more, use longer, and not always reversible with abstinence. And that's a great concern in relation to our young people. THC seems to be a problem. Some decisions are harder to make than others, as we all know. Here's a full listing of the cognitive functions that are improved with cannabis. That's right. Now, to be fair, there are studies out there with attention and concentration. Chronic users improves focus, occasional users worsens focus, but I argue that that is not an improvement in cognitive function. And the reason is we need both attention to something, but also respond to that. And if I'm over-focused here, I'm not going to be able to manage that peripheral element that suddenly intrudes into my space. So I remove that from the list. So imagination is really not looked at in the cognitive studies. Hashish gives the power of imagination, takes away the ability to profit from it. Baudelaire in a poem in the 1800s, as one of my patients said, they are couch locked. So what about motivation? Amotivational syndrome also is uncertain outside of the acute use. Absenteeism is up, if pre-employment THC is positive, decreased work commitment, energy and interest in adolescence goes down. As correlating features, I do think in my heart of hearts, if we were to sort it out, that amotivational syndrome is probably real, but we haven't looked at that. So I'm going to wrap this up in terms of the medical perspective for medical providers. What should we do as well? All patients should be screened for use of substances that are addiction prone. We need to counsel the patients that there is no evidence to support safe recreational marijuana use. We want to screen to see if they do have problematic use and end up with the diagnosis of addiction, if indeed that is there, because we can treat that, and to collaborate with individuals in our treatment team and monitor to make sure. I want to mention one thing in terms of the urine drug testing that Dr. Hildebrand was saying. It's really important to do confirmatory testing with Gcms and Lcms. You cannot rely on the cup because there are false positives and false negatives. For example, if I'm using tonics, I might end up with a positive THC on the cup test. You don't want to walk in the exam room or talk to your client about use of cannabis when in fact that's really not the case. You need to confirm those kind of things. And so I'm going to stop here if there are any questions, and I'm going to be around for the day as well. Thank you.